This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Ilara, Research Fellow. Today we're looking at a fascinating new study from the journal Fluids and Barriers of the CNS, published in 2026. It's a systematic review and meta-analysis titled Cognitive Assessment Methods and Outcomes Following Shunt Surgery in Idiopathic Normal Pressure Hydrocephalus, iNPH.
This is a topic that hits home for anyone in the OR or the clinic managing iNPH. We've all seen it. The patient's gait improves remarkably after a shunt, but when the family asks, will their memory get better, we often find ourselves giving a much more guarded answer. Historically, cognitive impairment has been cited as the symptom least likely to improve post-surgery.
Exactly, Dr. Aris. And this study, led by Lisa Healy and her team at Cambridge, really digs into why we have that uncertainty. They looked at 195 studies involving over 11,000 patients. Their main finding? The way we measure cognition in iNPH is, frankly, all over the place. They identified 193 distinct cognitive tests being used across the literature.
193 tests? That's staggering. It explains why it's so difficult to compare results between centers. But before we get into the how, let's remind our residents about the what. What are the core cognitive deficits we expect to see in iNPH?
The paper emphasizes that iNPH typically reflects a pattern of frontal subcortical dysfunction. We aren't talking about the primary memory loss you see in Alzheimer's. Instead, we see slowed information processing, psychomotor slowing, executive dysfunction, and apathy. These are the core domains that impact a patient's daily functioning and quality of life.
And yet the study found that a huge percentage of the literature ignores those domains, right?
Right. Incredibly, 54.4% of the studies reviewed did not formally assess any of those core iNPH cognitive deficits. Instead, many relied on subjective reports, NPH grading scales, or brief screening tools like the MMSE or MoCA.
Let's pause there, because the MMSE, the Mini Mental State Exam, is the bread and butter of many clinics. What did the meta-analysis show regarding these screening tools?
This is a crucial point for the trainees listening. The meta-analysis showed that while the MMSE and MoCA did show statistically significant changes post-shunt, those changes were largely within the range of expected practice effects. They don't adequately capture the core deficits of iNPH. If you only use the MMSE, you might conclude the shunt didn't work cognitively, simply because you used the wrong yardstick.
It's the floor and ceiling effect problem. If the test isn't sensitive to frontal subcortical speed, you won't see the recovery. So, Ilara, what did show improvement? Where is the signal in all this noise?
When the researchers looked at domain-relevant tests, the results were much more encouraging. They conducted meta-analyses on 10 specific outcomes. The trail-making test Part A, the grooved pegboard using the dominant hand, and the trail-making test Part B all showed changes that exceeded the thresholds for clinically significant improvement.
That's a powerful distinction. For the residents, remember that trail-making Part A is heavily focused on information processing and psychomotor speed, while Part B adds that executive component of set shifting. The fact that these showed clinically meaningful improvement suggests that shunting does work for cognition, provided you measure the right domains.
Precisely. The paper notes that when these sensitive iNPH-appropriate tools are used, shunt surgery is associated with both statistically and clinically significant cognitive gains. The authors mention that these findings should change how we interpret shunt response.
It also touches on the comorbidity issue. We know many of our iNPH patients have coexisting Alzheimer's pathology or cerebral vascular disease. How did the authors address that in the context of cognitive recovery?
They acknowledge that comorbid neurodegenerative pathologies can independently contribute to decline and attenuate the measurable gains after a shunt. This is why accurate standardized cognitive assessment is so important, not just for seeing if the shunt works, but for diagnostic accuracy in the first place.
Let's talk about the heterogeneity in the timing of these assessments. If I see a patient at 6 weeks post-op versus 1 year, should I expect different results?
The study found that follow-up times varied widely, which makes it even harder to define improvement. There is no international standard for when to retest. Furthermore, the criteria for what actually constitutes improvement were inconsistent. Some used a percentage change, others used a certain number of points on a scale, and others used subjective clinician impression.
This brings us to the summary box of the paper. It says this study adds to the field by showing that cognitive outcomes have been inconsistently reported and that cognitive improvement is reported less reliably than gait outcomes.
Exactly. But the how this might affect practice section is the real call to action. The authors are calling for a standardized iNPH appropriate cognitive evaluation tool. We need validated metrics for determining clinically meaningful improvement, rather than just statistically significant changes.
If you were a resident setting up a research protocol today based on this paper, what would your minimum viable battery look like?
Based on their meta-analysis results, I would definitely include the trail-making tests A and B and the grooved pegboard. These are sensitive to that frontal subcortical dysfunction. I would move away from relying solely on the MMSE or MoCA, as they simply aren't built to catch the specific psychomotor and executive gains we see after CSF diversion.
It's also worth noting the scale of this review. 1,876 records screened, 195 included. This is a massive synthesis. It really highlights that as a neurosurgical community, we've been a bit lazy with our cognitive endpoints. We focused on the easy wins, gait and bladder, and let the cognition data remain messy.
And that messiness has real-world consequences. If we tell a family that cognition is the least likely to improve, we might be basing that on decades of studies that use the wrong tests. This paper suggests that the cognitive benefit of shunting is likely underestimated.
That's a very optimistic take for our patients. If we use the same wording as the paper, it says, when domain-relevant cognitive measures are used, shunt surgery is associated with statistically and clinically significant cognitive improvement. That's a sentence I'll be quoting in my next clinic.
It also has huge implications for clinical trials. If we want to test a new shunt design or a new programmable valve setting, we need robust trial endpoints. Using 193 different tests across the world makes it impossible to reach a consensus.
So, to wrap up the key takeaways. First, iNPH cognition is about speed and executive function, the frontal subcortical circuit. Second, the MMSE and MoCA are often insufficient because they don't capture these domains and are prone to practice effects. Third, trail making and grooved pegboard tests are currently our best evidence-based tools for showing real improvement.
And finally, we need to move toward a standardized approach. The study concludes that this will enable accurate evaluation of cognitive benefits of shunting in routine clinical practice, not just in high-level research.
Well, this has been a great deep dive into a very necessary study. It's a reminder that neurosurgery isn't just about the technical skill in the OR, but about how we measure the impact on our patients' lives.
Absolutely. The paper is Cognitive Assessment Methods and Outcomes Following Shunt Surgery in iNPH in Fluids and Barriers of the CNS, 2026. Definitely worth a full read for anyone in the field.
Thanks for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.